What I'm going to talk about today is slightly different than the talk I gave a little while back. So my name is Kendrick Cato. I'm assistant professor at Columbia School of Nursing and also in the emergency department at Columbia University Irving Medical Center. I'm going to talk today about some work that we're doing modeling patients' risk for readmission that have been seen suspected for COVID. One second. So the way this started, our impetus for this project was basically during the surge. So during what we call the surge, where we saw an increased number of COVID patients coming through the emergency department at the Columbia University Irving Medical Center, the frontline clinicians came to the researchers and asked, how can we help them with determining basically if a patient who they suspected of COVID, that had COVID symptoms, COVID infection symptoms, if they should admit the patient or discharge the patient home. I want to remind folks on the call that one of the situations that we face in the emergency department is that there's a limited number of beds in the inpatient setting, and that becomes a rate limiting step. And so it's very important to try to figure out who are the patients that can be best served by being admitted to the hospital or discharged. And so that basically is the short-term work that we're doing. Our long-term work is to take some of the modeling that we're developing right now and build and kind of incorporate that into a clinical decision support system or tool for COVID patients, so that when COVID patients come in, there will be a clinical decision support intervention that a clinician can use, something in the line of some type of interaction in the embedded in the electronic health record to give them decisional support as to what they should do with that patient. So that's a long-term goal. And I also want to add that right now we're still in the process of modeling. So what I'm going to show you is just very preliminary results that we have. So, so our approach is a little bit different than other approaches. And so what we use is an approach that myself and a colleague of mine, Sarah Rossetti, who's also at Columbia University, she's appointed in Department of Biomedical Informatics and also in the School of Nursing. We developed a theoretical model that we call healthcare process modeling. And we use that in our data science modeling. And so basically what we do is we try to actually model healthcare processes. And we do that by looking at interactions in the EHR or in clinical systems. And those actual interactions become proxies for clinical behavior. And so we interpret these models, and what we're actually trying to model is clinician knowledge and expertise. And so we're not, in other modeling approaches, people or individuals or teams are trying to understand the patient state. What we're actually trying to model is what the clinician is thinking. And so that's very important. And that'll be reflected in some of the features or variables that you see that we use. And so in the process, it's very important to point out that we also incorporate clinician feedback in the process. So we work a lot with clinicians, and we usually, it's usually a very iterative approach where we build models, we present the findings in the state of basically a patient and what the chart looks like, and we ask the clinicians to validate, is the model actually classifying or predicting the type of patient or the situation that they would want to see. And so when we came together, we started having weekly meetings, and this is the team. It is a mix of physicians and researchers in the emergency department as well. So we have nurses as well on the team, so that we can model out basically the clinician interaction, both between nurses and physicians. And so in our model, we are using electronic health record data. And so what we are using, and again, we're looking at not values, but we're actually looking at patterns of interaction. So we're looking at things like vital sign entry frequencies. We're looking at the numbers of clinical notes that are written, the number of orders and the types of orders. And then also we're looking at nursing note comments. Nursing note comments are basically clinicians, but mostly nurses, in the electronic health record when they want to uh, add, you can think of it almost as a sticky, a post-it note into the EHR. They can right-click and add a comment. And we've found from previous work that we've done in the inpatient setting, looking at patient deterioration, that that the frequency, either the presence or absence of comments, it has a high signal. And then we also included demographics information like age, gender, race, zip code, and some others. And so the time period that we looked at, and so what you're looking at right now is a actual graph of the number of COVID positive patients in two of our hospitals. One, which is the main adult hospital in at the medical center campus, and then the Allen Hospital is the gray chart, and you can see that. And we have the time on the x-axis. And so we use this to try to figure out what time period we would use for training data. And so you could see that on March 5th, and so what we said was we took basically the start date was when we had 20% of the max number of patients that were testing positive that day. That was the beginning, and then the end period when it sloped down to that. And so you can see that the time period we used was from March 15th to May 5th. And that's reflected by, and these are positive PCR COVID tests. Also, I should note that we excluded a certain number of patients. We excluded patients that expired in the emergency department. We only looked at patients that were 18 years and older. And we also excluded patients that came in with any paperwork that indicated that they did not want to be resuscitated or intubated in the emergency room, and also if they were placed on that status in the emergency department. The reason we excluded these patients is because the pattern, when you look at the patterns of how clinicians interact with patients that do not want to be resuscitated, and also you see that it's a different pattern. So that's why we exclude these patients. And then also for patients that died, their data looks very different because we were concerned with patients that will come back to the hospital. And so these are the demographics. It's hard to see. It's hard to see, but you can see some interesting trends. We had patients that, and so we ended up with a sample of 5,068 patients. And you can see here that, excuse me, there's a fly here, that there is an interesting distribution of age where we had when you look after about the age of 35, there's a relatively even distribution in those categorizations. And then we have so let's talk a little bit about the surge model itself. So as I mentioned, the features we used were actually clinician orders, and that those would be prescribers, clinician notes, and those are nursing notes. And these are all written while the patient is in the emergency department. Any notes or orders that are written afterwards were excluded. So we used all the data until the time what we call the clinician disposition. And so that's when the clinician basically either puts in an order that they're going to discharge a patient home, or they put in a bed request for the patient to go into the inpatient setting. And so we looked at orders, notes, and vital signs taken. We also, I mentioned we looked at patterns of vital sign comments. We also used demographics, age, gender, race, ethnicity, language spoken, insurance status, and zip code. And I mentioned we also time to patient disposition. So the approach that we took was we first, and then also the outcomes. The outcomes, it was binary outcome for this task, and what the clinicians asked us was, they said, from an ED clinician perspective, they would like to know if they discharge a patient, if that patient will return in 72 hours to the emergency department, and then be admitted inpatient and stay inpatient for 24 hours. So that was, so basically we had two classes. One were patients that were admitted to inpatient and stayed there for 24 hours, or patients that were discharged and then came back within 72 hours and admitted to inpatient and stayed for at least 24 hours. Interestingly enough, initially we thought we were going to have a multi-level outcome where we thought that there were going to be patients that there were going to be a significant enough number of patients who went home, came back, and within 48 hours, or went home and came back between 48 and 72 hours and were admitted. But when we looked at the data, we actually found that there were a very small number of patients that left and came back within 48, less than 72 hours. They were admitted, and so it turned into basically a binary outcome where if you came back, if you left and came back within 72 hours, you were grouped with the patients that were admitted into the hospital. And then the other outcome was whether if you were discharged and you didn't return within 72 hours. So the approach we took for our statistical learning was logistic regression, random forest classifier, and a boosted decision tree. And for our feature selection, we actually did an initial step where we used a random forest algorithm to identify the features that contribute to classification. And so the features that actually
Kendrick,
ended up in our—
this is a two-minute warning.
Sure. The features that ended up in our model were clinician orders, time to disposition, that's how long it took for clinicians to decide to admit a patient or discharge a patient home, age, language spoken, race, zip code, insurance status, and then the patterns of vital signs measured. And we broke those patterns into a number of different features. We looked at overall count while they were in the emergency department. We looked at the average of shortest time and also the average of shortest time between measurements. And that was to get a sense of if for some reason clinicians were measuring, or they increased their surveillance of a patient, and then they were measuring the patient's vital signs very often. And so the models that we've built so far, and I say so far because we're still working on it. We're still doing some feature engineering. So for our linear model, all of the models perform relatively well. You can see here with the approach that we've taken. But by far, the gradient boosted model performed better. And so our future work, we're going to continue to do the modeling. In previous work that we've done in looking at other patient deterioration, we know that we can go back and do some additional feature engineering to do better prediction. And then we also need to do some validation with clinicians, actually pulling out cases and showing them and getting their feedback about what the model's telling us about those patients. And then finally, there's a longer term work we'll do to actually develop a clinical decision support intervention, and we'll have to figure out what, working with clinicians, what the best mode of intervention would be, whether it's an alert or an app, or a hybrid of that in the electronic health record, and where it would fit in the workflow, and then validate that intervention. And so this is again the research team, and I want to thank them for taking time out, especially when most of them are clinicians, during COVID, working very hard, with a lot of stress. So thank you. And if anyone has any questions, that'd be great.
Thank you, Kendrick. Again, if there are any questions, go ahead and raise your hand. Peter Wire, you can talk.
Oh, great. Okay, yeah. A question about the exclusion of DIE patients. Assuming that they are not also DNR, the issue is, were these patients moribund on arrival? Were they prospectively identifiable as extremely severe? Otherwise, the question is what the time frame of your planned support. In other words, when would your support kick in? Would it be within an hour of arrival in the ED, 2 hours? Because the DIE patients may be a good challenge to that decision, given that patients might arrive in the ER looking fairly stable, then deteriorate, then die. But from what you said, you would be excluding them.
Yeah. So just to be clear, the question, the clinical question clinicians. So for clinicians during COVID, the clinical picture they had and what they felt like they needed decision support for were not patients in that situation. It was more the patients where they had seen the patients, evaluated the patients, and then had decided either the patient should be admitted inpatient or sent home. They felt that there was not enough evidence out there, clinical evidence, to decide. They wanted more clinical decision support to think about, is that patient going to come back and to me? And from an emergency medicine standpoint, what they defined clinically was that if they discharge a patient, the patient comes back within 72 hours, then they should have kept the patient. And so for the type of patient that you're referring to, that wasn't really a question that they felt like they needed. So clinicians were faced with that situation, but for this specific research question, that wasn't the question that was being answered. The situation where a patient comes in, that has a do not intubate order, and then they crash sometime during the stay. I also want to add, in our findings, the length of stay for patients were relatively short, much shorter than the average length of stay before COVID. And so patients were coming through the ED fairly quickly. And so that scenario, that adds to the context of the DI, do not intubate patients. And again, clinicians felt that, for the do not intubate patients that they were treating, they didn't really need that kind of clinical decision support.
Well, my question was not the DNI patients or DNR patients.
Oh.
The patients who died in the emergency room, but might have looked fairly stable coming in. And
I see.
Excluding them, that might actually interfere with the accuracy of your results.
No, that's a good point. We did talk about that because, but one of the, from a modeling perspective, we decided to exclude those patients just because it was hard for us to discern in the data a patient that came in, in that short time period might have looked fine initially and then crashed. And so we did decide to exclude those patients for that reason.
Okay,
But that is
we
a good
have
point.
one more question from Marina Bonanno. Marina, you should be able to talk.
Yes, can y'all hear me?
We can hear you
Yes.
now, Marina.
Okay, great. Kenrick, great talk. I feel like I have to take up the torch since I don't think Margaret is here. So my questions were basically based on ethnicity and race. And if you notice changes based on whether or not people were not admitted, if they were subsequently turned away and then, you know, later expired.
So we, you know, so this work is, our modeling approach is based on work that we've been doing in the inpatient setting here at New York Presbyterian and also up at Partners Health System in Boston, looking at basically surveillance, clinician surveillance of patients that are deteriorating and how surveillance is predictive of patient deterioration. And what we found in that work to date, and we have a clinical trial going on right now, is that there is a difference in levels of surveillance for patients who are not white. In the data that we have in the emergency department, that holds true as well. So we did find that there's a different level of surveillance for patients based on their race and their ethnicity.
Okay, we have one more question coming from Margaret. Margaret, can you talk?
Yes. Hello. Good morning, everyone. I am in fact here. Thank you for that wonderful talk, Kendrick. And again, thank you also for just pointing out what I was actually going to discuss or ask you, and that is if there are in fact biases that are leading to the disparities in impact. Is that correct?
So I want to choose my words carefully because you know, the analysis that we've done so far, it wouldn't be accurate for me to say yes to that question. But I would say that that we can detect a bias in clinician workflow. I think there's more work that needs to be done for that. And we are doing that work right now, but there is, you can see there is a difference in the data depending on both socioeconomic and race ethnicity status.